Oppositional Defiant Disorder by Rosemary Roberts. A normal part of the development for 2-3-year-olds and early adolescents, particularly when tired, hungry, stressed, or upset, is to be oppositional. However, when the behavior becomes openly uncooperative and hostile to the point when it occurs so frequent and consistent that it stands out when compared with other children of the same age and developmental level, and when it affects a child's social, family, and academic life, it may be said that this is a child with oppositional defiant disorder, ODD. ODD is one of the more common mental health disorders found in children and adolescents. This disorder is often accompanied by other serious mental health disorders, and if left untreated, can develop into conduct disorder, CD, a more serious disruptive disorder. According to DSM-4, oppositional defiant disorder is defined as a recurrent pattern of negativistic, defiant, disobedient, and hostile behavior toward authority figures. Oppositional defiant disorder is characterized by the frequent occurrence for at least 6 months of at least 4 of the following behaviors: losing temper, arguing with adults, actively defying or refusing to carry out rules or requests of adults, deliberately doing things that annoy others, blaming others for their own mistakes or misbehavior, being touchy or easily annoyed by others, being angry and resentful, and being spiteful and vindictive. The results of an ambitious study conducted by Lahey, Frick, Lobert, Tannenbaum, Van Horn, and Price 1990 indicate that oppositional, defiant, and aggressive characteristics were located on one end of the dimension, the overt symptoms. The symptoms are usually seen in multiple settings, but may be more noticeable at home or at school. 1 to 16% of all school-age children and adolescents have ODD. ODD usually appears in late preschool or early school-age children. In younger children, ODD is more common in boys than girls. However, in school-age children and adolescents, the condition occurs about equally in boys and girls, although the disorder seems to occur more often in lower socioeconomic groups. ODD affects families of all backgrounds. Although there is no clear-cut cause of ODD, most experts believe that a combination of biological, psychological, and the social factors and social risk factors play a role in the development of the disorder. Biological factors. Children and adolescents are more susceptible to developing ODD if they have a parent with a history of attention deficit hyperactivity disorder, ADHD, ODD, or CD. A parent with a mood disorder such as depression or bipolar disorder. A parent who has a problem with drinking or substance abuse, a brain chemical imbalance, poor nutrition, exposure to toxins, a mother who smoked during pregnancy, impairment in the part of the brain responsible for reasoning, judgment, and impulse control. Psychological factors: a poor relationship with one or more parents, a neglectful or absent parent, a difficulty or inability to form social relationships or process social cues. Social factors: poverty, chaotic environment, abuse, neglect, lack of supervision, uninvolved parents, inconsistent discipline, family instability such as divorce or frequent moves. Some conditions that coexist with ODD are ADHD, anxiety disorders, mood disorders such as depression and bipolar disorder, learning disorders, language disorders. According to Dr. Susan Anderson, professor at University of the West Indies, Mona, Jamaica, children whose behavior is not considered normal are often treated with a lack of understanding and empathy on the part of teachers and their peers. Such treatment leads to negative student behavior and results in poor academic performance. Amongst these children are those with special needs and learning disabilities. They suffer most at the hands of teachers and administrators who construe exceptionalities such as hyperactivity and oppositional defiant disorders as rude and disgusting. This is due to their inability to identify children with emotional and behavioral disorders. The Jamaican educational system is woefully unprepared to cater to the needs of these children, and we can say the same for Antigua. She further suggests that 80% of all students identified as having emotional and behavioral problems are educated in regular schools. The Jamaican educational system and other countries in the Caribbean which face similar problems have yet to create a national system where children can be referred, assessed, programs planned and implemented to meet the needs of students with exceptionalities. What now entails, in our view, is vastly limited. Dr. Anderson's study showed that incorporating the use of technology, especially the computer, is an intervention used in the school systems to cater for the needs of children with oppositional defiant disorder. Teachers' experiences showed that children who misbehaved are labeled as deviants are subject to corporal punishment. The teachers felt that the training that they had received at Teachers College did not adequately prepare them to treat children with EBD, and so they had to use their own initiative. However, those who use the technology think it can be helpful to the child. The computer does not criticize the child who is using it, and it facilitates learning without the pressure of being judged in a subjective manner. Thank you very much.